Welcome, billing students and clinic staff. If you've ever stared at a patient's insurance card and just thought, why in the world did this claim bounce back unpaid? Well, you're absolutely in the right place. Today, we're putting on our expert medical billing educator hats for this instructional explainer to untangle some of the most misunderstood corners of the Medicare universe. We're going to decode these plans and, most importantly, prevent those claim denials. Okay, here's our agenda for today to clear up all that pervasive front desk confusion. We're going to cover Medicare Part C replacement plans, the specific coding rules for Part C, then Medicare Part D prescriptions, Medigap supplement policies, and finally wrap it up with a quick summary. Let's jump right in. Section 1, Medicare Part C replacement plans. We'll start right at the setup, understanding the absolute basics of Part C. Honestly, this is where so many billing errors originate. The absolute most crucial point you need to remember, Part C is a total replacement plan. It's offered by private insurance companies that Medicare has officially approved, and it completely replaces traditional Part A, your inpatient hospital coverage, and Part B, the outpatient medical coverage. It bundles the whole shebang into a single plan. And frequently, to entice enrollees, these private plans will throw in extra perks like prescription drug coverage and routine vision benefits. So, how does the money actually flow? Well, Medicare funds these plans by paying private insurers a fixed monthly capitation rate. Basically, that's a predetermined chunk of money every single month to manage and administer all of that patient's care. In exchange for that steady government funding, the insurers have to agree to run things in strict adherence to Medicare's overarching baseline regulations. But here is where it directly impacts you at the billing desk. You've got to be aware that these private plans enforce distinct, plan-specific constraints. Since they're managed privately, they can dictate completely unique out-of-pocket costs for your patients. They can enforce strict in-network doctor requirements. And, this is a big one, they often require mandatory primary care referrals before a patient can even see a specialist. If you miss that referral step, boom, the claim gets denied and your clinic doesn't get paid. Also, just a quick heads up on how the demographic landscape is shifting right now. Many large employers are increasingly transitioning their retiring workers directly into these Part C group plans instead of keeping them on traditional company retiree policies. What does that mean for us? It means you're going to see a lot more of these Part C cards sliding across your desk. So, knowing exactly how to handle them is absolutely critical. Moving right along, Section 2, Coding Rules for Part C. Okay, let's take this knowledge and actually apply it. Knowing what a plan is only half the battle, right? Knowing how to bill it is how you actually secure your clinic's revenue. Listen, before you have any interaction with a patient, before a single clinical service is rendered, you absolutely must execute this pre-service verification workflow to eliminate avoidable claim rejections. Step 1, verify the coverage is active. Step 2, check your provider's network participation. Are you actually in network for the specific private plan? And step 3, confirm those authorization rules. Do they need that primary care referral we just talked about? Doing this early is literally your best defense against non-payment and massive headaches later. And this brings up a brilliant point about the hierarchy of contracts in the billing world. If your provider's commercial contract with the payer outlines a distinct Part C fee schedule, one that differs from standard Medicare, well, the payer must follow those commercial terms, not the standard Medicare guidelines. That commercial contract is legally binding for your reimbursement rates, so always know what your clinic's specific contract dictates. Our training text hits on a golden rule here. Early verification prevents unnecessary appeals. By jumping into Medicare contractor web portals and IVR, that's the interactive voice response telephone systems, early in the process, you're building a fortress around your clinic's revenue cycle. It prevents those unnecessary, incredibly time-consuming appeals. Do the heavy lifting on the front end, and trust me, the back end takes care of itself. All right, pivot time. Section 3, Medicare Part D, prescriptions. Let's talk about Medicare Part D because it causes an enormous amount of confusion at the front desk every single day. Part D is strictly for standalone outpatient prescription drug coverage. Much like Part C, these are managed by Medicare-approved private organizations. Eligible folks have to explicitly join a plan and abide by its specific limitations just to get their medications covered. Now, you might be thinking, I don't dispense retail drugs. Why do I care? Well, while Part D rarely impacts medical billing directly, it profoundly affects your patient intake process. Why? Because beneficiaries frequently and incorrectly assume their Part D drug card is a comprehensive medical supplement. They'll hand it to you fully expecting it to cover their doctor's visit copay. No way.
This means you have to step into an educational role. It falls on you to clearly and politely explain to patients that Part D covers pharmaceuticals only. You have to clarify that it's never going to pay their medical coinsurance for an office visit, and it absolutely does not cover their annual Part B deductibles. Look, managing patient expectations right here at the desk prevents some really angry phone calls when they get their patient statement later on. Which brings us to the actual solution. Section 4, Medigap Supplement Policies.
When a patient actually needs help paying what original Medicare doesn't, Medigap is exactly what we're looking for. 20%. That number represents the vital gap coverage principle. See, original Medicare typically pays 80% of allowed charges once the patient meets their annual deductible. That leaves a 20% gap. Medigap policies are designed specifically to step in and cover that remaining 20% coinsurance that Medicare leaves behind. It fills the gap. Make sense?
But keep in mind the strict coverage exclusions. Medigap is entirely dependent on Medicare's initial adjudication. Basically, Medigap only pays for services that original Medicare authorizes first. If Medicare looks at a claim and denies it as non-covered, Medigap is absolutely not stepping in to save the day. It only supplements what is already approved. Now, when you're assessing a patient's secondary cards, it's crucial to remember that a standard secondary commercial major medical policy often totally fails to benefit a Medicare recipient compared to a true Medigap policy. Those commercial secondaries, they come with their own deductibles and a whole maze of complex coordination of benefits rules. A true Medigap policy, on the other hand, seamlessly coordinates to just pay that remaining 20%. So, the core billing question you have to ask yourself every single time you evaluate a patient's secondary insurance is this: does this secondary plan cover what Medicare allows but does not pay for? If the answer is yes, you're almost certainly looking at a true Medigap policy. I love this direct quote from our training text because it perfectly sums up the exact financial function of a genuine Medicare supplement. Let me just read it for you. A genuine Medicare supplement acts as a gap coverage to compensate for the medical expenses that Medicare authorizes but does not pay for. It's simply a financial bridge, compensating the provider for the authorized medical expenses that original Medicare leaves to the patient's responsibility. All right, let's wrap this up. Section 5, Summary and Next Steps. Let's quickly recap the critical distinctions we've covered in this explainer to make sure you've got these foundational rules locked down for your daily practice. To summarize our big three, Part C, which we often call Medicare Advantage, completely replaces traditional Medicare, meaning you have to follow the specific commercial network and authorization rules. Part D is exclusively for pharmacy prescriptions. It won't pay your medical claims, so be ready to educate your patients. And Medigap, that's your true secondary supplement, existing specifically to pay the 20% medical coinsurance that original Medicare leaves behind. In our next training module, Part 8, we're diving deep into the strict world of Medicare compliance. We're talking MACs, LCDs, and ABNs. Well, you know exactly when to make a patient sign an advance beneficiary notice before they get stuck with a massive medical bill. We're going to cover exactly how to protect both your clinic and your patients. As you head back to your desks today, I want you to ask yourself, how many thousands of dollars is your clinic losing every single month just because a front desk card scan was misinterpreted? Master these basics, and you stop those leaks right at the source. Like, share, subscribe to Decode Healthcare with Harshal.